This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Clinical Interventions in Aging, published in 2026. It's titled Percutaneous Endoscopic Decompression versus Non-Operative Care for Radicular Pain in the Oldest Old with Lumbar Stenosis, a target trial emulation focusing on pain relief and deprescribing.
This is a timely topic, Alara. We are seeing a rapidly growing population of patients aged 80 and older, what the paper calls the oldest old, presenting with symptomatic lumbar spinal stenosis, or LSS. Historically, we've struggled with these patients. There's a lot of therapeutic inertia because of their age, multimorbidity, and the risks of general anesthesia.
Exactly. And the authors point out that our current evidence for this demographic is pretty thin. Most non-operative care data in octogenarians is low quality, and while open surgery works, the tissue dissection and anesthesia are real hurdles for frail patients. This study looks at PTED, percutaneous transforaminal endoscopic decompression, as a middle ground.
Before we get into the results, let's talk about the methodology. They used a target trial emulation framework. For our residents listening, can you break down why they chose this over a standard retrospective review?
Right. In a typical retrospective study, you often have immortal time bias or selection bias, where the healthiest patients get surgery. A target trial emulation applies the rigors of a randomized control trial, like a strictly defined time zero to observational data. They looked at 143 consecutive patients aged 80 or older at a single academic center who had unilateral radicular symptoms and MRI-confirmed LSS.
I noticed the inclusion criteria were quite specific. They all had to have failed at least 3 months of conservative management, and, this is crucial, they all underwent an ultrasound-guided diagnostic nerve root block to identify the symptomatic level.
Yes, and time zero was the day after that block successfully relieved their pain. So from that point, they were either channeled into the PTED group, which was 75 patients, or the structured non-operative care group, which was 68 patients.
Let's dive into the PTED procedure itself, as described in the paper. We're talking about a transforaminal approach under local anesthesia. For a surgeon, the technical advantage here is the targeted resection of the hypertrophic ligamentum flavum and partial undercutting of the facet joint. It's an indirect decompression of the central canal, but a very direct decompression of the lateral recess and the foramen.
And doing it under local anesthesia is the big selling point for an 85-year-old with multiple comorbidities. No general anesthesia, less physiological stress. But did it actually work? Their primary outcome was 90-day comprehensive treatment failure.
That's a very patient-centered metric. They defined failure as unplanned rehospitalization, treatment escalation due to uncontrolled pain, or a serious complication. What were the findings?
The results were quite striking. The PTED group had a significantly lower incidence of treatment failure, only 16% compared to 44.1% in the non-operative care group. After they adjusted for variables using inverse probability weighting, the adjusted odds ratio for failure in the PTED group was 0.18.
0.18. That's a massive reduction in the odds of failure. And if you look closer at the why, the paper says it was primarily driven by pain-related failure. They calculated a number needed to treat, or NNT, of just 3.7 to prevent one pain-related treatment failure. In our world, an NNT under 4 is excellent.
What really caught my eye, though, was the benefit-risk ratio. Usually, when we offer surgery to the oldest old, we worry we're trading pain for complications. But in this study, the complication-related failure didn't differ significantly between the PTED and non-operative groups. They calculated a favorable benefit-risk ratio of 6.6 to 1.
That's a key point for the residents. We often think non-operative means no risk, but in this population, uncontrolled pain leads to immobility, which has its own set of serious risks. The study shows that PTED is not just effective, but relatively safe because it avoids the big hit of open surgery.
We should also talk about the long-term outcomes at 12 months. This wasn't just a 90-day flash in the pan. The PTED group showed a greater improvement in the Oswestry Disability Index, about 9 points better than the non-operative group. But the most modern metric they used was deprescribing.
I'm glad you brought that up. As neurosurgeons, we don't always think about polypharmacy, but for an 80-year-old, being on 5 or 6 different medications for pain is a major health hazard.
Exactly. The study found that at 12 months, the PTED group had a significantly lower prevalence of polypharmacy, with an adjusted odds ratio of 0.14. By effectively treating the pain source, they were able to reduce the overall medication burden. The authors call this the deprescribing benefit.
It's a holistic way of looking at surgical success. We aren't just opening the hole, we are potentially reducing the risk of drug-drug interactions and falls associated with chronic pain meds in the elderly.
Now, to be fair, we have to look at the limitations. It is still a retrospective emulation, not a prospective RCT, and it was a single academic center.
True, and the patients were carefully selected. They all had unilateral symptoms and a positive response to a diagnostic block. That's a specific subset of LSS patients. If you have someone with multi-level, bilateral, severe neurogenic claudication, PTED might not be the answer.
But for that specific phenotype, the octogenarian with a clear single-level radiculopathy, this data is very supportive. The paper concludes that PTED should be considered a first-line therapeutic option for this group.
It challenges the traditional ladder where we try months and months of injections and meds until the patient is too weak to ever recover. If PTED is as minimally invasive as this paper suggests, maybe we should be intervening earlier to preserve mobility.
The authors actually mentioned that these findings justify the need for a formal prospective randomized trial. But in the meantime, for the practicing surgeons listening, this provides a pretty robust framework for counseling these old patients.
To summarize for our listeners, in patients over 80 with unilateral radicular pain from LSS, PTED under local anesthesia showed a significant reduction in 90-day treatment failure compared to structured non-operative care. It also led to better functional outcomes at 1 year and a significant reduction in polypharmacy.
And that benefit-risk ratio of 6.6 to 1 is a great number to keep in mind when talking to families who are hesitant about surgery because of the patient's age.
Absolutely. It's about the right procedure for the right patient. This paper makes a strong case that PTED is a valuable tool in our geriatric spine armamentarium.
That's all for today's episode. We'll link the full study in the show notes.
Thank you for joining us on the Neurosurgery Hub podcast. Until next time.